Good afternoon, everyone. Today, yes, Sunil, you need to put hand right. Can you hear me, Sunil?
Just talk, Prakash. I can hear you.
Go ahead.
Good afternoon, everyone. Today, I regent of Patan. I'm going to start a presentation on management of stroke. Uh, First of all, the initial goals phase, including when the patient arrives in our emergency department with different complaints, we should first of hello. We should first of all initiate whether the patient is of stroke or not. After
Dr.
hello.
Prakash,
Screen है ना screen.
sorry for interruption. Your screen is not visible. Can you please send me the slide in the bio, please?
Yeah. Okay. 1 minute. To be done. The initial assessment to be done in ER while patient arrive is first of all we should ensure the airway, breathing, and circulation. Determine whether the patient is of acute ischemic stroke or candidate for intravenous thrombolytic therapy or endovascular thrombectomy can be done in this patient. Determining whether the pathophysiologic basis of the stroke first of all, we should at the at ER. First of all, we should look for the ABPDE. That is, first of all, we should go for the airway of the patient, whether the airway of the patient is. Whether the airway of the patient is intact or not, and therefore we should see for the breathing, disability, and exposure. Uh, uh, and exposure by exposing the patient. Uh, in case of disability and exposure, we should first of all we should know whether there is any history of trauma or not, whether the trauma took place due to fall after stroke or before stroke, and that should be ruled out before managing the condition. Next slide, please. In management of hypoxia, first of all, we should look for the GCS level of the patient, and after that, we should look for the saturation of the patient, whether it is less than 94% or above 94%. If it is less than 94, if it is above 94%, then it is normal. We should not have to do anything further for hypoxia. But if it is less than 94%, then oxygen is required either by nasal prong or by face masks according to the requirement of the patients. If the patient needs high flow oxygen, then it could be given by nasal prong or by face mask as per the requirement, and till the saturation is increased above 94%, and after that we can in most of the patient requires high fraction of inspired air, that is FiO2, which can be given by different methods, and patient may get improved. And other alternatives, next slide too. And other alternatives we can also have is like placement of LMA tube for if there is a difficulty, and we can go for intubation and bag and masking and ventilation. Intubation and mechanical ventilation can also be done for the further improvement and for the further management of the patient. Next slide. In management of hypovolemic dehydration, in ischemic stroke, hypovolemia, it depends on volume depletion, particularly in acute stroke and in old age person. In volume depletion, which can cause by deficient blood or oxygen supply to the brain. It should also be individual based on electrolytes and cardiovascular status of the patient. We can use to correct hypovolemia by using isotonic saline, that is NS, and we should avoid DNS, glucose containing fluids like DNS, and half isotonic saline. Next slide, please. We should also check for the GIBS level of the patient at initial. The target blood glucose level should be up to 80 to 179 mg per deciliter. In case of hypoglycemia, hypoglycemia can cause focal neurological defects, which can mimic stroke, and several hypoglycemic can cause neurological injury. Check and correct blood sugar if it is less than 60 mg per deciliter or 3.3 mmol per liter at the first opportunity. And if it's so hypoglycemia, a sugar more than 126 or 7.0 mmol per liter, common in patients with acute stroke and associated with poor functional outcome. Hyperglycemia augment brain injury by increasing tissue acidosis from anaerobic mechanism, free radical generation, and increase blood-brain barrier permeability. So treat hypoglycemia and manage blood sugar level to decrease up to less than 180 mg per deciliter. Next slide, please. In similar condition, we also see if there is fever or not in the patient. If there is fever, that may cause brain injury in acute stroke. It may also act like several mechanisms to worsen cerebral ischemia, like enhancing release of neurotransmitter, exaggerate oxygen radical production. It also more extensive blood-brain barrier breakdown. It also increase number of potential damage, ischemic depolarization of focal ischemia, impaired recovery of energy metabolism, and enhance inhibition of protein kinase, worsening of cytoskeleton. So to prevent from this, we should initially record the temperature of the patient, and it could be if it is high, we can give antipyretic drugs, and it can be managed. Next slide, please. Next slide, please. When the patients arrive in our department, the position of head is also very important. In position of head, if back, please. If intracranial pressure, back, please. It also one slide agadi, forward, please. Elevate intracranial pressure, that is intracranial hemorrhage, and cerebral edema more than 24 hours from stroke onset in patient with large ischemic infarction. It also can cause aspiration, those who have difficulty in swallowing. If dysphagia or diminished consciousness was present, cardiopulmonary decompensation or oxygen desaturation with chronic patient like chronic illness like pulmonary disease or cardiac diseases. Next slide, please. Swallowing assessment should be done. Dyspepsia is common after stroke. Patient cannot swallow. Which causes major complications like aspiration pneumonia. Before giving medication to patient, it should be assist by giving a sips of water, or whether by seeing the gag reflex of the patient, whether it is present, whether the gag reflex is present or not, before giving medicine. Or otherwise, if we give medicine and if the patient develop aspiration pneumonia, then it will be there will be a further complication. And so to prevent this, we should first of all check whether the patient is able to swallow or not. If the patient is not able to swallow, then we can place NG tube. Keep patient NPO if the patient cannot swallow. Next slide, please. Management of blood pressure in patient with ischemic stroke. The target blood pressure is less than one. Systolic blood pressure is less than 220, and diastolic blood pressure is less than 120. If blood pressure is more than 220 by 120 mmHg, then we can give short-acting medications to reduce the blood pressure. In initial 6 hours, to decrease the blood pressure of the patient. Next slide, please. Next slide, please. Management of blood pressure in back, please. Management of blood pressure in patient requiring thrombolysis. The patient who requires thrombolysis, the pressure range should be, the systolic pressure range should be less than 185, and the diastolic must be less than 110. If the blood pressure is more than 185 by 110, then we can give labetalol, short-acting IV medications to reduce blood pressure. To reach the target blood pressure, it should be done in initial 24 hours. Next slide, please. Management of blood pressure in patient with hemorrhagic stroke. In case of hemorrhagic stroke, first of all, to prevent from seizure, we should give anticonvulsant drugs, and to reduce BP if the patient have already is under chronic illness or under any other medications. We should give antihypertensive drugs to reduce blood pressure. Any osmotic diuretics also can be given to decrease intracranial pressure and in the subarachnoid space. Next slide, please. If systolic blood pressure is more than 200 mmHg or MAP more than 150 mmHg, then consider aggressive reduction of BP with continuous intravenous infusion with frequent BP monitoring with in every 5 minutes. And if the BP is more than 180 mmHg or MAP is more than 130 mmHg with possibility of raised ICP, then consider monitoring ICP and reduce blood pressure using intermittent or continuous IV medications while maintaining cerebral perfusion pressure more than or equals to 60 mmHg to 60 to 80 mmHg. If systolic blood pressure is more than 180 mmHg or MAP is more than 130 mmHg, and there is no evidence of elevated ICP, then consider a modest reduction of BP. That is MAP of 110 mmHg or target BP of 160 by 90 mmHg using intermittent or continuous intravenous medication to control BP and clinically re-examine the patients in every 15 minutes. Next slide, please. Antithrombotic treatment in ischemic stroke or in transient ischemic stroke in the management of the patient with acute ठ्याक्कै स्क्रिनको बिचमा आएको छ। In the management of patient with acute ischemic stroke involves several phases. The goal in the initial phase is to ensure medical stability, which we used to do when the patient arrived uh, in our ER, and then after determine whether the patient is eligible for thrombolytic therapy or mechanical thrombectomy, which we can decide after reaching patient in our ER and after doing CT scan. In addition to the perfusion therapies, for acute treatment, there are two major classes of antithrombotic drug that can be used to prevent recurrent stroke. That is, antiplatelets drugs can be used and anticoagulants can be used as antithrombotic drugs. Next slide, please. Commonly used antiplatelets drug are antiplase and tinactinase. For treatment more than 4.5 hours of stroke, antiplatelets lead to a good outcome, and if beyond 4.5 hours, there is a decrease. Decrease in the good outcome, and antiplase can be altiplase can be given at 0.9 mg per kg of actual body weight with a maximum dose of 90 mg. 10% of this dose is given as an intravenous bolus over 1 minute, and the remaining is infusion over 1 hour. Next slide, please. We should also look for the ABCD score too. If the ABCD score is more than 4 or equals to 4, we should admit the patient and evaluate for the patient further further evaluation should be done, and it should be monitored regularly. And if the patient ABCD score is less than 4, MRA, ECG, Holter, blood sugar, T, tropi, RFT, INR, lipid profile, CBC, and carotid Doppler should be performed. And the treatment, if there is no evidence in MRI, then tablet aspirin 75 mg and tablet clopidogrel 75 mg for 21 days can be continued. And if there is a evidence of minor stroke in MRI, tab aspirin and clopidogrel 75 mg can be continued for further for 90 days. Next slide, please. This is a protocol of stroke in our partner hospital in the Department of General Practice and Emergency Medicine. There are two symptoms. One is traditional symptoms and one is non-traditional symptoms. In traditional symptoms, there is a sudden numbness or weakness of face, arm or leg, especially unilateral, sudden aphasia, sudden dysarthria, sudden memory deficit, or septal orientation or perception difficulties, sudden visual defect or diplopia, sudden dizziness, gait disturbance or ataxia, sudden severe headache with no known cases, with no known causes, and another is non-traditional symptoms like impaired consciousness, syncope, shortness of breath, acute onset, like generalized weakness, altered mental status, dysphagia, shortness of breath, sudden pain in face, chest, arm, seizures, fall or accident, sudden hiccups. These are all non-traditional symptoms which patient can present uh, to us with these symptoms also, and to exclude this whether this is a first of all we should rule out whether it is a symptoms of stroke or not. To exclude, we should first of all rule out seizure, hyponatremia, syncope, meningitis, migraine, brain neoplasm, subdural hematoma, subarachnoid hemorrhage, it should be ruled out. And after ruling out, if we found the symptoms are progressive in nature, then it could be stroke. If the symptoms are statics and or the symptoms is not progressive, and it is getting relief, then it can be TIA, or minor stroke can be uh, mm, minor stroke can be thought after that. And when we think of stroke, then we should further do uh, uh, workup like uh, next slide, please. Mm, if we think it as a stroke, then we can do the investigations like CBC, random blood sugar, sodium potassium, lipid profile, APTT, PTINR, tropi, ECG, echo, carotid Doppler, and CT scan. CT scan should be done. And then after that, if we think uh, if it is a TIA, then we should go for ABCD score. If it is more than equals to 4, admit the patient. Investigation and treatment should be done. And uh, if we think it is a stroke, then we should go for the investigations, and then after that we should treat the patient. If it is duration less than 4.5 hour, and if hemorrhagic stroke is excluded, if we think it is not an hemorrhagic stroke, then we should go for NIHS class. If it is more than 4, or NIHS less than or equals to 4 with deficit like aphasia, anopsia, distal paresis, then before thromboembolysis, we should see whether the patient's age is less than 18 years, or more than it, whether he or she has trauma of head in last 3 months or not, subarachnoid atrial puncture in last 7 days, history of uh, intracranial neoplasm or intracranial hemorrhage, malformation, neurosm, seizure, recurrent intracranial surgery, or whether systolic blood pressure is more than 185 mmHg, or diastolic blood pressure less than 110 mmHg, active, if there is active bleeding or not, if whether there is platelets count less than 1 lakh, or INR more than 1.7, or APTT more than 15 seconds. Then if it is present, then we will go for again airway breathing and airway management. And then after saturation should be more than 94%. Target BP should be maintained like less than 220 to 120 mmHg, and temperature should be less than 38 degrees centigrade, and blood glucose less than in between up to 140 to 180 mmHg. Uh, then we should perform swallowing test, and then after that we should give aspirin and atorvastatin at starting with aspirin of 300 mg stat by NG tube, and atorvastatin 80 mg by NG tube stat. Mm, and if uh, and if and if these all are if there is no evidence of this, then active thrombolysis treatment or patient should be referred to neuro center for further uh, management. Mm. And after investigation, we go in CT. If we see vascular territory or multiple vascular territory, then small then we should see it is small or multiple or recurrent ischemic lesion or large or cortical lesion. If there is a small multiple or recurrent ischemic lesion, then we go for angiogenic emboli. And if there is a large or cortical lesion, then we go for cardiogenic emboli after doing D-dimer. And if there is multiple vascular territory involved, then neoplastic coagulopathy should be ruled out by tumor screening. Sorry. Uh, and if there is CTD or coagulopathy, then lupus should be ruled out, and anticoagulant, anticardiolipin, beta 2, glycoprotein, ANA, ANCA, protein C and S, any antithrombin 3 should be done. And if there is aortic arch emboli, then CTA should be done. And if is less than 50 years, then again we should rule out uh, uh, vascular coagulopathy like lupus. Uh, and in case of TIA, then we will see for ABCD scoring more than if it is more than or equals to 4, then admit the patient and investigate. If it is workup should be continued, but the patient can be discharged. But the patient should whether with aspirin 75 mg, aspirin 75 mg and clopidogrel 75 mg for 21 days. And for further evaluation, MRI evidence of minor stroke, then dual antiplatelets for 90 days should be continued. And if not, then we can manage according to the report of MRI or CT scan. And my references are from Tintinelli, our Medscape, medical, and from our department site, Department of Emergency Medicine and GP of PAS. Thank you. This was the total management protocol of our emergency department, which was